It's 1 o'clock, so I just want to say good afternoon and welcome to the first of our continuous quality improvement sessions as part of the Modern Ward Round Collaborative. I'm Wendy Rees and I'm one of the QI coaches. I work with ECIST and I'm with my colleague today, Nick Holding and Crystal Skinner. So ideally for the session, if you can stay on mute, that would be fantastic. Crystal can control the mute if we do get any background noises, but this session really is designed as sort of as you begin your improvement journey. We're just going to give you some ideas to sort of prepare your projects and foundation, and also to help you with the engagement with your team on the project. So a bit of listening today, if that's okay. If you've got any questions, of course, you can put your questions into the chat box. We haven't got a formal Q&A session as part of this, and what we're going to do is that any specific questions around your project or around the collaborative, we're going to pass your questions to your QI coaches, who should all have been in touch with you by now. But if you have any problems, please do let Crystal Skinner know. But what we'll do is we'll collate those questions and give them straight to your QI coaches. Obviously, if you've got any technical questions or questions about this event as it's going on, Crystal will be able to answer those as they come in. So do please say if you can't hear or you've got a particular problem. Hopefully that's all right. I think really I just want to sort of start the session by saying this is an introductory. I want you to, we've got a number of approaches. I want you to enjoy the session. It is only an hour, but it is an introduction, and obviously all the resources, all of the tools and approaches we talk about will be available to you. They'll be on our Futures platform, but we've also got some direct links for you after the session as well. So please don't worry if you haven't quite taken note of what we're saying. You will be able to access all the resources that we talk about today. Okay, so the first session, I'm going to hand over to my colleague, Nick Holding.
Thanks, Wendy. Good afternoon, everybody, and welcome to this session. So as Wendy said, my name is Nick Holding. I'm an improvement manager with the Emergency Care Improvement Support Team, and it's lovely to see so many of you on the call today. Hopefully you'll enjoy this session. I want to talk really to start off with really about how we prepare the ground for improvement. One of the things that we come across a lot with our improvement experiences, that we see improvement journeys where we haven't done the groundwork often. We haven't prepared the soil in if you want to use that kind of analogy, to even begin your improvement work, and we try and impose, or we try and plant our improvement work in unfertile. So what I want to sort of cover a little bit in this first session is about some thoughts and some techniques and some tips around how you may think about preparing the ground and doing that preparation work before you even begin your improvement work. I think one thing we always recognise, we recognise a lot, is that we know that, or as Eli Goldratt says, we know that any improvement is a change. So we know that's a fact, but we also know that not every change is an improvement. I think we've all seen supposed improvement work that has taken place, but did it actually lead to an improvement? So it's really important to understand about, is the changes that we're going to make going to lead to an improvement? And we'll touch on that a bit later on with some of the tools that Wendy's going to share with you. So because there's some facts that are around, there's really important number this is, and there's a global survey done by McKinsey's and repeated several times since, that 70% of change efforts fail. This is across all industries, across the world, but we've seen this repeated, and I've seen this myself within healthcare, and the numbers still kind of stack up, that around 70% of change efforts fail. So you have to start thinking about, well, why is that? Why do so many of our improvement efforts, when we put so much resource and so much effort into that, why do they fail? For me, it probably isn't the 70% that stands out as much. It's the additional 25% that only achieve some of their objectives, and therefore only 5% of improvement efforts lead to a sustained change or improvement. And again, going back to that point, we put a lot of effort into improvement work. We put a lot of resource, time, commitment, energy into improvement work, trying to get things better. But if you realise, but looking at those numbers, you think we have to do something slightly different. Looking at the reports that came out and looking at some of my experience over the last sort of 18 years of doing improvement work, these are the kind of themes that come out of those why change efforts fail. So really important to set out with really clear expectations of your improvement work. What is it you're trying to achieve? What's your aim? Then there's some links in communication and buying, and we'll touch on that a bit later on in the session. But for me, probably the most important aspect is the improvement mechanism, the how we do improvement. If it's imposed, if it's done to people, it's probably not going to succeed. If you haven't done the preparation beforehand, if you don't understand your current state, those kind of processes, the improvement effort probably won't succeed. And if you think about all the effort that we put it in and all those over those years and years of work that we put in around improvement work and all the time that we've been doing this, you start to ask the question, if you do suddenly realize you're riding a dead horse, isn't it time to get off and try something different? I want to tell you a little story, something I share and use quite a lot in my improvement work. And it comes from a little story called Winnie the Pooh. Here's Edward Bear now, down the stairs behind Christopher Robin. Bump, bump, bump in the back of his head. It is, as far as he knows, the only way of coming downstairs. He is sure there must be a better way. If only he could stop bumping for a moment to think about it. If we think about how do we build in that thinking time into our work, we probably have some preconceived ideas about what the improvements are that we need to do. But how do we build in that thinking time to ensure that they're the right ideas? This quote from Einstein, I think, is really helpful. We cannot solve our problems with the same thinking that we used when we created them. So we have to do something different. We have to do something fundamentally different to make the changes that we want. We can't just do the same old, same old. But that also means having to actually do something. We have to take action. We have to try things out and experiment. Because, believe it or not, just because we think things are going to happen or we hope things are going to happen, it doesn't actually mean that it will happen. So sometimes we have to be brave in our approaches and actually try some things out, expecting that some things won't work, some things will work, and we have to understand how those move forward. Because we find often the simple answers are not often the right answers. Sometimes we have to take difficult decisions. We have to take test difficult ideas out because they may be the right things that actually make that shift. The simple answers, often what we find is that it's kind of based on the same thinking that we already have and just gets us back to the same place that we've always been. So the well-trodden path gets us to the same place. We have to be start thinking about maybe that less well-worn path, the one that we haven't really tried too often. Now's the time through something like the collaborative, which is a well-structured program, to maybe start testing out some of those different ideas that you may have, being experimental. Because ultimately what it comes down to, and several quotes here allude to the same kind of thing. If we've always done what we've always done, we'll always get what we've always got. So this is about trying something different, being brave, moving things on. We can't just do the same things over and over again and expecting different results. So as we start to think about how you prepare for your improvement journey right now, how do you start to harvest and pull together many different ideas from many different areas across all your teams now on the wards that you're working on, to try and understand, can we do something different? Is there something fundamentally different that we can do? But above all, I think the thing that jumps out to me is that there's often a rush, there's often an impatience around improvement work that leads to a launch into solutions that may not be the right solutions. So my advice at this point is take your time. It really is okay to take your time at this point to understand how you can build the right understanding of your current state. And again, Wendy will touch on that in the next session. You really do have time for improvement. You really have time to set some allocated resource aside to think about the work. We often launch straight into active improvement work and think about things in terms of we must be busy, we must be doing. We don't think about thinking time as improvement, but it is so important that we build in that thinking time now, and before you even start to try anything out in terms of practical improvement steps. I mean, this quote for me reflects that. I'll tell you a story. It's not healthcare related, but I'll tell you a story which kind of, I think, emphasizes the point to me. It is from Toyota when they developed the Prius engine and the hybrid engine of the Prius car, which was revolutionary for that sector. So no other hybrid engine or no other electric engine had been built at that point. And we recognise now, that is a common thing now, electric engines and hybrid engines. But when Toyota built the Prius, this was a brand new concept. They give themselves a 2-year window from design to launch. They were going to go to a particular motor show and launch their Prius. That changed very quickly to 1 year. They set themselves a 1-year aim to launch the Prius, from initial design concept that we want to develop a hybrid car to actually getting it at the motor show. They spent 9 months preparing and getting themselves ready and learning and understanding it even before they started the journey of producing the car itself. So they had that significant lead-in time to ensure they understood what they needed to do before they even started. And sometimes what we find too often is that we try and build the aeroplane as we're flying it. We kind of launched into the work and then trying to improve it as we go. Now, I'm all for testing things out and experimentation, but really understand the direction that you're going in before you start that. Because as this quote from Stephen Covey says, if your ladder's not leaning against the right wall, every step you take just gets us to the wrong place faster. So understand your direction, understand your aim, understand where your improvement journey needs to lead to, and you'll do that by engaging with your teams and developing some improvement ideas through them. This comes really from a point of view that you start to understand what you need to do and where you need to go to. But fundamentally, how do you understand your current state? Where are you now in your journey? What does your current ward round process look like? What's the readiness of your teams at this point? What's the engagement like? What's your current state? Because often we find with improvement or any kind of project work, our expectations are quite linear. There's a start point and the end point, and we travel that journey. The reality is something often very different, and there are pitfalls and successes and deviations and learning opportunities and a few battles in there as well, a few scary moments and a few opportunities for celebration as well. The reality is often very different. So how do we factor these things in? By understanding where we currently are, understanding where we get to, but being flexible and being able to modify our approaches as we go, and building as a true learning journey rather than a project management focused action plan which delivers on a particular linear timescale. And you'll do that by to truly understand your current state. Fortunately, most of you here on the call right now, you are ward based. You know what happens in your environment, but it's important to as this quote from Fujo Cho says, you go see, ask why, you show respect. So speak to your people, go see them, talk to them, ask them about what are the issues, what are the rocks in their shoes that get in the way of them doing a great job every day. What are the challenges? Ask why does that happen? Ask why many times to get to the root cause. You show respect by encouraging other people to offer their suggestions. Because as going back to the Toyota industry, to Toichi Ono, who developed the Toyota production system, he says, data is of course important, but places greater emphasis on fact. If you made judgment purely based on data, you'd have a very different picture that if you got some real life feedback from the teams and from yourselves who are working. So data can only tell one story. It's important that you get some verbal feedback as well, because we know that the majority of issues are around the systems and processes. It's not about the people. I'm a big believer in this. It's hardly ever the people. It's more likely to be the processes and the system. My starting point is that people don't come to work to do a bad job. People very rarely are the issue. So look at the systems and the processes. How do the interaction? We work in a complex adaptive system. How do we understand the interdependencies of the processes? How do we understand how each of our component parts work together? And look at the system as a whole rather than individual parts of them. But the people in those processes often find themselves in a situation where they're working in poor process, and they're frustrated by the waste and the delays that happen. I'm sure you all experience that in one shape or form or another through your world. So if we start to judge people around the process, and we start to judge it's based on the people, not the process, we're into different territory. And as Eisenhower says here, you don't lead people by hitting them over the head. That's assault, not leadership. We'll start to bring this section to a close. I'm going to hand back over to Wendy in a moment, just to sort of run through a few tools that might be helpful. I want to share with you this There's kind of a tool, it's kind of a mindset, it's more of an improvement routine, and it kind of encapsulates some of the things that I've just talked about. So this is the thing about an improvement habit. If you developed an improvement habit, think about these kind of steps in the process. So number one would be get the direction right. Be clear about what your aim is. What are you trying to achieve through this collaborative? What's your overall objectives for the piece of work? Then move to step two, grasp the current state. Understand where you are now, both from a process perspective, staff engagement, staff experience, patient experience, all the qualitative and quantitative data that you can pull together. Understand where you are now, which is why I said it's worth taking the time to do that now, to give yourself a really good foundation for the work. Then step three is establish your next target condition. So this is not about going from step two to achieving your aim. You want to build in a number of small incremental steps that you can chunk up into manageable pieces of work. So think about your next target condition. So an organisation that I'm working with at the moment, their next target condition is to get nurses attending ward rounds. So there are a number of ways that we can do that, and they're working through a number of experiments around, is it the bay nurse, is it the coordinating nurse, is it a drop-in, so they're testing all those out, but that was their next target condition around their overall aims around improving the ward round process for patients. And you start to conduct those experiments leading up to the next target, and then you go again and again and again as you move through the cycle. So I'm going to hand back to Wendy, and Wendy's going to share with you a few tools that you may find helpful.
Thank you, Nick. That's great. So for those that joined just a little bit later, you haven't missed loads. We are recording the session, but Nick has been talking a lot about how important it is to prepare the foundation to your improvement project as part of the ward round collaborative. So I'm going to talk a little bit more around some of the tools and some of the specific ways you could do this. I'm a nurse and I quite like simple things that I can do, but also a little bit of structure as well to help us think as a group. So hopefully you'll find this interesting. So as Nick has alluded to, the first rule of quality improvement is identifying the problem. So try not to jump to your solutions, but to really think about, what do I know? So look at the information that you have. We provided you with a self-assessment, which is part of the Royal College of Physicians guidance that obviously this collaborative is based on. The self-assessment template within that is a starting point for you to have a look at areas that you think may need improvement. And many of you have completed those and sent them back to us, which is great. And for those that haven't done that yet, then that's probably the first thing to do. It's a really quick and easy way to get everyone together and have a think through where you are with ward rounds. And again, you really do need to have a think about the cause. So, is a symptom a real cause or an effect of a problem? I'll talk a little bit about that in a second, but your improvement work should focus on the cause, not the symptom. And when you use approaches and tools, one of the best ones is to talk. And as Nick has already said, talk as a team and observe. And you've got the privilege of working on the wards, how things work, and you can see what's happening, and it's a really good starting point for improvement to be there on the ground. You've got sort of qualitative, so that is sort of thoughts and thinking and information from patients and feedback, and you may have some data which is more quantitative around length that a ward round takes, or some data around your ward in terms of length of stay, etc. So there's a range of information you can use. Audit is another way of establishing sort of your current state, and you may have a number of audits anyway in place, and maybe you could use some of those to help to understand some of the sort of ward round processes and where the patient participation is. So please do have to think about what you currently have in terms of audit. And patient feedback is so important, and we gather it at all opportunities. So again, look at your patient feedback, and that'd be a really good source of information. I'm going to talk through a little bit around some of the QI tools and approaches, and I've picked 5 that I particularly like, but hopefully these will be useful. Bear in mind, there are resources that you can access, and we'll give you all that information. So there are other tools that you may choose to use. I'm going to go through the 5 whys, an affinity diagram, I forgot my one, process map, that's all right, process map, value stream mapping, and driver diagram. Thanks, Nick. I just wanted to just talk a little bit more about cause and effect. And one of the places we can see this, and I find an easier example to explain, is waiting time, say in a planned care pathway, or somebody who's waiting for an outpatient's appointment. The waiting time is the effect, and that's the effect on the patient, and that's what happens, and that's what we see. But actually the causes to the waiting time can be quite complex, you know, from the environment in terms of how many clinic spaces there are and how easy it is to park, to the methods in terms of how we engage with patients, whether they have to come in and whether that's 1 or 2 visits, the equipment in terms of diagnostics, are we able to do a one-stop shop, or will they then need to wait for another intervention? And obviously the people, you know, how many people have we got to run a clinic, and the skills and expertise required. So they're all of the causes that may result in waits. Thanks, Nick. So working together, this is really the most important thing when you're doing any quality improvement. You know, it's not one thing you can do alone. It's about working with people. And we used to work in big groups, didn't we, when we used to be able to do conferences and workshops and all get together. And obviously, you know, we're working slightly differently. And the photograph on the right is me doing some work with some team members in Hampshire. And yeah, well, I was miles from them. But it was still okay. It was face to face. We made it work. It was safe. And I think it's about generating the ideas in the best way that you can. You work as a team on the ward, so hopefully that means you're face to face quite a lot of the time. But again, don't jump to conclusions. Do that groundwork. It's really important. So the 5 whys is a simple way to start to find the root cause. So when you've done your self-assessment, you can ask, where are we now? So with one of the issues you might have highlighted from your self-assessment, you can consider the issue and ask yourself as a group, ask why up to 5 times. And it might sound a bit monotonous, but it's a way of generating ideas. So I put an example here that the end of the ward round is so rushed that some patients don't have time to ask questions. So, you know, you're asking, so why? You know, well, when we are not planned, we don't to start at the same time, we are waiting for some people to arrive, we have to wait to look things up, we don't know some of the patients, and we have to start from scratch. So once you've done that sort of exercise, and that can be on post-its or flip charts or however you want to do it, you can generate some ideas to test, and Nick will talk a little bit more about testing ideas later. And this is really, you can test new start and finish times. You could test planning in advance of board round, and you could test how we can take information with us. So, you know, it just starts to maybe formulate your ideas in a sort of more collaborative way. Thanks, Nick. And when you've done the sort of 5 whys and you've had that sort of discussion, you can then start to put maybe it into a structure. And this is called an affinity diagram. So this is where you can break things down into themes. So you've got the main theme, which is the running out of time for the ward round. You've got the sort of groups that you've got themes for, so patient experience and planning and information. Actually, then you can break it down into single items, and it can be as long as you like. But you know, you've got less time for patient to discuss concerns. The ward round's not sufficient. The board round's not sufficient to prioritise the ward round. You've got new patients but limited information. You may have patients that have come from the emergency department and the information hasn't come with them. So you're just grouping some of the ideas you've got together. It helps you work as a team, and it helps you group the similar ideas. Everybody then feels they're participating, and it generates that team ownership and the consensus. Thanks, Nick. So we can come on to something else when we've done that, but which is process mapping. Excuse me while I have a bit of water. It's so warm today, isn't it? So process mapping, I don't know if any of you have been involved in process mapping, and it might seem a bit of a but it's actually really quite a useful way of establishing your current state. And like with any QI tool, you can do it really complex, high level, or you can do it really, really simplistic to whatever you need to do. And I always say, just start simple. So when you do a process map, you can start to expose areas of duplication, You can look at waste and variation. It gets people together across the team. So if you're doing a ward round process map, you would maybe involve the pharmacists and other people that support the ward round. And then it helps you sort of the next step to identify the next step and where the processes can be improved. And you can start to just look at one area. You don't have to improve the whole pathway. But yeah, I like the cake one too. Thanks, Nick. So this is actually a process map from a junior doctor that's done a project. It's a BMJ article and it's worth reading. This is a surgical ward round, and obviously, you know, it looks quite complicated, but you know, when you read through it, and obviously you'll be able to have a look at these slides afterwards, it's quite small on the screen. But actually, the ward round starts. So to the left of the page, at the bottom is where the ward round starts, and it's really where the junior doctor joins the ward round with the consultant. You can see the varying sort of pathways along it. So the rectangles will represent steps. The triangles are where something might change, so like a decision point. So where you've got a decision point, it's like sometimes a bit of yes or no. So for example, in this one, it's actually the junior doctor having the information for this patient. And if it's a no, then they go down a different bit of the process, but they have to go and get the information, come back to the ward round. So you can see where you deviate on pathways sometimes, and that might be where you might think there's a bit of you know, wasted time and maybe an opportunity for improvement. And on this process chart, they've put some red indicators on there saying where information may be missed. So they've really started to highlight some of the risks around some of the process. So I think this is a really good example, but it is quite a complex one. So don't feel you've got to do it to this level. Thanks, Nick. When you've done a process map at whatever level you think is useful for your project, Nick and I are big fans of value stream mapping, and it's another additional point you can add to a process map. So this brings in a little bit more detail. It's a little bit more around the observation as well, and you can identify the steps within the process and their value to patients. So when we consider value and non-value added time in healthcare, we generally are thinking about points in the pathway where patients may not be having a huge benefit, and it might be where they're waiting for something. Can be simple or complex as you like, as with the other one, and you can always just have a go. And it should include observation and feedback. So when you do value mapping, you're actually walking the process as if you were doing it. So you might want to do it on a ward round, or you might want to do it as a sort of a practice ward round, but you actually walk the process and notice things as you go along. And also you can time the different points in the journey. So Nick, I've just got an example on the next slide, please. Oh, I just wanted to say waiting obviously is risky for patients. And when we do value stream mapping in healthcare, it's really important, because what we can highlight is the waits, how this increases anxiety, and also that most complaints are secondary to poor communication, and generally it's people waiting to hear. So I think this is a really important point. Thanks, Nick. So a value stream map that I've done myself in an emergency department. I know this is very small, so you won't be able to read it, but I just wanted to show you how you can actually do this. You can do it as a team. It can involve as many people as you like, but actually this was a process map of patients arriving in an emergency department as walk-ins, going to the streaming area and then going on to triage. And with the value stream mapping part of that, you then start to add in the times it takes, and also the times where we would class it as a wait, so the sort of queuing times as well. When we did this value stream map in the department, we actually found, and we were able to use the data from the times, we actually found that the average time from arrival to triage was 64 minutes. And for those that have worked in an emergency department, that's not the ideal. If you've got somebody who's very unwell, you do want them to be triaged, you know, within the first sort of 15 minutes. There was significant waits resulted in more non-value than value-adding time. When you added up the times of waiting, it was far more than the time that actually patients were in an interaction with anybody. And of course, you can observe the environmental factors. So I could observe the fact that the streaming nurse was on her own, and she was dealing with all of the patients waiting, and that was quite distressing for her. And there were things like no access to water, and it was actually the year before last, and it was as hot as this. There was no water for patients, and of course they're waiting a long time. So this formed part of the QI for this trust. So it's one part of their information. So it's about gathering lots of information together. But actually, when we've done some tests for change, we managed to get the streaming down to 15 minutes because we value stream mapped again. 15 minutes, nurses working together across streaming and triage, so just increasing the capacity. And then we were able to gather some feedback. So the staff liked it, the patients are seen and treated much quicker, so they felt it was safer. And there was one lady particularly that was streamed that was clearly unwell and actually had sepsis. And actually within 30 minutes, she was having IV antibiotics. If she'd been in the previous scenario as a walk-in patient, she may not have been seen for an hour. And we know how risky that is for patients. Thanks, Nick. So you have some ideas now, hopefully, and this is about formulating your ideas of some tools and approaches to do that. So now it's time to plan an improvement project. One of the really good ways of doing that is to use driver diagrams, and it's a good way of communicating what you're doing, and it's a good way of planning. To help plan your project, you can review it and update it as you go along, so it can be a live document. It doesn't have to be a point in time. It can be updated. It's structured and helps you stick to your aim as well, and also outlines the activities which result in the improvement. Thanks, Nick. Now, this is a really, really complex driver diagram, so please don't think you have to create something like this. But I wanted to show you, this is really program level driver diagram. This is an actual real driver diagram from last year around reducing length of stay. So this will be something that trusts would have as part of their program. You can see the aim is clearly articulated in the first box. This is what everybody is aiming towards, and it's ensuring that patients stay in hospital for the minimum time required. There is some outcome measure there as well, and that's up to you. And our next QI session will be on outcome measures and evaluation. So it's really, it's up to you if you want to put that in, but you don't have to. It depends on the type of project that you're thinking about. Then you've got the list of primary drivers. So this breaks down then what is it what change is going to happen that's going to lead to your aim, and you can almost categorize them. So where you've done your infinity diagram, you can almost categorize some of those into what you think will achieve your aim. So, for example, I'll just read the top one. So, rapid identification of patients at risk of prolonged inpatient stays. So that's a really important driver towards reducing long stay in hospital. And the secondary drivers will be the sort of projects and tests for change you might do, which is about screening patients on arrival for frailty, effective screening tools widely available, and therapy and senior medical review at the front of the pathway. So these are your test for change ideas. So this is a very complex driver diagram. So I just thought you could do something small for your particular project. I'll just have a sip of water. So the example I gave you, I think I gave it on the launch event, was that all patients staying in the ward are involved in discussions, decisions during the ward round by midday. So a little bit of time in there, but a really distinct aim of what you're trying to do. So that's the effect. And then you've got primary and secondary drivers. So your primary driver may be, one person at eye level with the patient during the ward round. The patient is left with a short note explaining the outcome of the discussion, and the patient and any relatives or carers are able to answer the 5 questions, those being, why am I here, when am I going home, etc. And then the causes that will result to the effect that we want. Thanks, Nick. Just a little bit more detail. So explain to you, so your test for change may be explain to the patients on admission the importance of their role in the ward round, so that when you're at eye level with them, they're not alarmed. Agree the roles of the ward round, so who's going to be the person providing eye contact, and agreeing who's going to write the note and providing a simple pro forma, and again covering the 5 questions in your discussion, and then the relatives and carers being invited to the ward round. So those are sort of tests that you could do. Thanks, Nick.
I was just picking up on that, Wendy. I think so. When we on the launch event, I shared with you, those of you on the launch event, I shared with you the model for improvement. This is a really great way to bring in that model. Is when you think about those secondary drivers, these are those ideas that you're going to test. So you can be really clear about what you're trying to accomplish. So you've got those secondary drivers. Then you think about measurement. How will you know that change is improvement? So what's your metric there that's going to know that? Then you test lots of ideas to how you're going to introduce that driver. So it's a really natural way as you develop your driver diagram from understanding your aim through to actual practical tests of change using the model for improvement. So just coming back to the model that I shared with you earlier, where we fit in the model of improvement is through the experimental stage. So we've done again, very much linked to the driver diagram. You've got your overall aim at step 1, you've got your current state. Your step 3 really is your primary drivers there. You're starting to think of what's our next target condition. So as Wendy described, we're having discussions with patients at eye level. That will be your next target condition, and then you use your model for improvement to incorporate into the actions there. So I just wanted to bring that into that discussion there, because I know that I shared that with you at the launch event.
Thanks, Nick. So what's next? So as we said, there's access to all the QI resources that we've spoken about, and it's really important as part of the engagement to communicate your ideas, and you may be familiar with formats like 30, 60, 90-day plans, but in a really simple way, we're just talking about actually what it is you're trying to achieve and the steps you're taking towards that. And it's really important, once you've done your self-assessment and you've had your discussion, for you to complete a driver diagram, because I think it will really help to frame your thinking. Thanks, Nick. So this is a simple format for ideas for action, and it's got an ABC. So it's really about, in the next month, what could we do to speed up and do more of? So what can we accelerate in the next 2 months and in the next quarter? So you're just chunking it up into bite-sized pieces, manageable pieces. What could we stop doing? So this is about putting a brake on. So when you do your process mapping and you've had your discussion, there may be things that are obvious that you could stop and that aren't adding any value at all. What could we start doing? So what could you create? So this feeds into, again, the aim, the long-term goals. It's just different ways of framing what it is you're trying to achieve. And what you can start doing, again, in those bite-sized pieces. What should we do? What's the test for change here? And again, with all of these templates and documents, they're not set in stone. You can adapt and change, and it's just a way of planning and communicating your ideas. Thanks, Nick. And again, so a driver diagram, it is a relatively simple thing to design. There are some templates available if you want to use a template, but again, it's about the big box at the beginning is your aim, and that's what you're driving towards. What are you trying to achieve? And again, smaller changes to achieve that aim, and then again, the changes that you're going to test. What's going to contribute to the small changes that will result in the larger change that you want. So again, this is just a driver diagram example. Thank you, Nick.
Thanks, Wendy. That was really helpful for everybody, and there's lots of content that we've got on our Futures platform, so do download it from there if you want to access it. So I want to, just as we wrap the session up now, as we come towards the end, this last section now, I want to sort of reflect back on something that we picked up on from the launch event. When we asked you the question, what was the first thing you're going to do? What's that one thing you can do? And resoundingly, the thing that came back was the fact that you wanted to start engage with teams and start to share and start to speak to your team. That was the overriding thing. So I thought, well, probably helpful to sort of touch on that a little bit and maybe give you some thoughts around that in the first place. And somebody I've read a lot about at the moment and reading a few of his books, a guy called David Marquet, ex-submarine commander in the US Navy, he talks about, if you want people to think, give them intent, not instruction. So think about, don't jump to solutions, don't tell people what to do, help them frame the problem for them to help other people to solve the problems. So give them a sense of intent rather than instruction. And I wanted to share this model with you. And this is a really helpful model, and I've used this for as long as I can remember. I don't know. It originally comes from public health, but it's a really helpful way to frame the approach to improvement. And the model states that for those who are interested, it's stage of change from Francesca de Clemente and Norcross. It's a way of moving through to developing a new way of working or a new habit or a new way of being. So you could apply this to work, you could apply this to yourself. If you wanted to become, I don't know, you wanted to start a new exercise regime, or you wanted to give up particular you want to give up cake, going back to Wendy's process map before, or whatever it was, or you wanted to start to do something new, the process is still the same. So we all start at a position of pre-contemplation. We don't know the need for change, we're not aware of the need for change, we haven't necessarily seen the data yet, we haven't joined a call like this or whatever. We're in a state where actually we think everything's okay. Then we move into a place where we've probably seen some data, or someone's explained things to us, or we've understood something slightly differently, and we move into contemplation. And then we move into preparation phase, and then we move into action before we move into maintaining the actual action we have. What we often find now with improvement work is that some of us go through this journey, and the model states, and the research behind it states, that everybody has to go through the steps incrementally. You can't jump from one to another. You have to move incrementally, and some people will move quicker than others. But what we often find is that some of us go through this journey and we've acquired the knowledge, and then we go back to our teams and say, we've got a brilliant idea and we're going to launch it on Monday. And we've not given everybody else the opportunity to move through from pre-contemplation, where they may be in a position where actually we think it's all right. We don't get a sense of urgency here, and we're asking them to launch from pre-contemplation straight into action, and that's not going to work. So depending on how well you explain your aims, and the people that you're working with they'll work through these processes, work through the model, and as I said, some will be quick, some will take a bit more time. And these naturally fit in this kind of curve. I mean, many of you will recognize this curve. Those innovators, those early adopters, those people who just want to be part of something, anything new, they'll be the ones that move through that model quite quickly. You can explain it to them. They just want to be part of something different, and they'll move. Yeah, give it to me, I'll go. You know, those energetic people that I think we all recognize. As we move along the curve into the early majority, late majority, then we're starting to think those a bit slow, and we need to think about what our communication is, how we get those people on board. As we move into the last section, I don't actually like the term laggard. I prefer the term skeptic. These are people who they will give us some helpful feedback. If we haven't described it well enough, those people will tell us. So thinking about those skeptics, they're the people that are probably still using an analog phone, or they aren't using, they've still got a Nokia 3310 in their pocket or something like that. So Chris, yeah, you got a Nokia 3310. So you move through this journey, and some people will move quick, as I said, but some will move slow. So think about what your communication is. Think about how you describe it to people, that everybody understands what the aim is, and make it visible. Some of the things that Wendy was sharing there, like the ABC tool, there's nothing wrong with blowing that up into A1 size and putting it up on the wall so everybody can see, and they can stick post-its on it or whatever. It's about how you can engage with that, help people to understand how they form part of this piece of work as well. So as you go back and start to communicate and engage with people, just recognize this model. It's probably one of the most helpful things that I picked up in, is understanding this model and the research that sits behind it. So one of the things I recognize is we do get fixated on the solution, on the end point, and we end up thinking about just making a change. So if we're thinking about creating a plan, just by producing a driver diagram isn't going to make the change you want to make. You have to lead on to do something as well. So sometimes we're focused on writing action plans and producing templates and driver diagrams, but we're not thinking about how that actually leads into the change itself and the goal. And the goal is the goal here, as Peter Fuder says. It's not the change itself. So think about what you're trying to achieve, and there may be all sorts of different ways of achieving that. There's not a single route to that overall aim. And recognize that people have lots of different opinions, and it's good. You should embrace diversity of thought across your people. If you are surrounding yourself with like-minded people, you'll probably all end up speaking the same language and see things from a very singular perspective. So look at the people that are in the group. Do you need to look at who else you might bring in from a different perspective? Get those skeptics in, get those people who are going to challenge the prevailing thought. Their views will be, from their perspective, will be as right as yours. So it's just about different perspective and different opinions, and it's important to encourage that in that time that you when I talked before about how you build in thinking time, think about how you bring people to the table to give them a chance to contribute. But one of the things I wanted to share with you, which I think is probably more important than anything else that I think we've shared, is just this understanding around the knowing and doing gap. Because I think we're in a situation where we find ourselves so often where we know that we know the need to change, we know what we need to do, and theoretically we can talk it and we can say it and we can believe it, but moving into and launching into the doing bit, into this that shift into the doing and actually making things happen. In the middle, I've found regularly there is this barrier, and often that's based on a fear of failure or incorrect assumptions or whatever it might be, but just something that gets in the way. And that fear of failure gets in the way so often, and it's worth uncovering that a little bit and thinking about how you can start to build an environment and build a climate with your improvement work where failure is seen as an opportunity for improvement, where you learn from those failures, where failure actually is a good thing because you can try things out and you allow people to be experimental and testings. So many people on this call right now will have a clinical background, and you'll have a scientific methodology about the way you approach, where things have been tried and tested. You have a hypothesis and you work them out. I encourage you to try the same thing. We would have not got to the place to where we are now from a medical perspective without lots of failures and experiments along the way. It's exactly the same with our improvement work. Why would we assume that the first time we try something, we would expect to get it right? So building that failure, but it's about how you build in enthusiasm and try those things out and encourage it as you go along. So one of the things that I use this quote a lot, and I've referred to this quite a lot from Henry Ford. It's just that's simply the opportunity to begin again, but this time more intelligently. You learn so much from that failure. You don't write it off, and too often we'll bin something. So yeah, it didn't work. Told you it wouldn't work, and we bin it rather than reflecting and thinking about what didn't work, why didn't it work, what bit did work, but what bit didn't work, and how can we improve that? So failure is always the opportunity to think again. And I talked about David Marquet before, and this is something from his work around how he thinks of things in terms of red work and blue work. And the red work is the doing bit. We always get a little bit trapped in the doing stuff, the hamster wheel. You know, we've got to be doing stuff all the time. We haven't got time to stop and think. We've got to be doing. But blue work is so important. That's time to reflect and think and plan and change and understand and improve. But the thinking here is the privilege of blue work is often given to certain groups of people, probably the leaders, the higher ups, the management, and the workers, the doers. They're the ones who do the day. They aren't given the opportunity to be involved in that blue work thinking time. But that's very much that industrialized thinking where you have bosses and workers, and we're involved in that. Work is based on physical labor. We're not in that world anymore. We want to encourage thinking. We're in a thinking environment. I mentioned before, we operate in a complex adaptive system. Everybody is a cog in a very, very big complex machine. So it's how we can bring all that thinking and allow everybody to be involved in that thinking time and reflecting that blue work that's so important. But ultimately, and it comes down to one simple thing in the end: are we prepared to make that leap of faith into a place where we want to be better than where we are now? And by whatever metric you choose to make that judgment, just move from where we are now to where we want to be. And that requires a leap of faith. That takes bravery. That's what we talked about before. It does take a shift into actually moving things forward and doing things, and how you start to engage your teams and start to communicate the message into that place where you want to be. Nobody's going to make that leap of faith with you if you can't describe what it is that you want to be in the future, because there's risk inherent in that, in leaping into the unknown. Most people, unless you're one of those crazy innovators that on the left hand side of the curve, don't tend to launch into the unknown. So bringing things to a close now, I just want to share with you where I believe that we're at the moment on the journey, and again trying to manage the expectations and trying to build a level of patience around this work as well. Where you're at the moment is the blue bit, the first 3 sections, about how you're starting to think about creating a sense of urgency. This is Kotter's 8-step model for anybody who wants to have a look a bit more detail at this. You're looking at building a sense of urgency. Where's the need for change? Why do we need to change? You're creating a small guidance team. They're the people that you've pulled together already around the 2 wards that you're working on, but also then about getting the vision right before you start to communicate widely for that buy-in, and then you move through into empowering action. So you're very much in the blue space at the moment, steps 1 to 3, moving slowly now into 4 and 5, and then you move into, by the time you got through to the end of the collaborative, you're starting to get into that place where you're at 7 and 8. So just looking at, we should not expect people to be thinking in terms of making things stick within the next month or so. We think about how do we make things stick in the long term. Don't have short-term thinking, because that short-term thinking ends up in short-term results. They just dissipate and die away. So it's a bit of a journey. This is the first step. You've joined the launch event, first QI event. You are starting to think about your improvement journey. It is all improvement effort is hard, and there are dips and there are successes and there are opportunities to change direction as you go. But think about how that journey is going to pan out for you. But I think for me overall, this is an opportunity to do something different. This is an opportunity to join a collaborative with 14 other organisations across the country, and actually make that change you probably wanted to do for some time. The reason this was completely voluntary, this collaborative. People weren't sent, people weren't told to come or chosen, and they had to come along. This is entirely voluntary. So you all wanted to do this, and I think so that shouts at me that actually there are a group of people here who want to make a change, who want to try something different. So now's the opportunity. So use the opportunity through the collaborative. Use your coaches. Use the network that we'll look to establish across all 15 organisations as you go, and make the most of the opportunity. And I'm going to leave you with one last quote before I hand back to Wendy. And it's somebody who used to live some time ago just up the road from me, up in Shrewsbury. It's from Charles Darwin. And Charles Darwin says, it's not the strongest of the species that survives, nor the most intelligent that survives. It's the one that's most adaptable to change. Wendy, back to you.
Thank you, Nick. So we've tried to design the QI sessions to reflect the journey you're on over the 6 months. So as Nick says, this is the very early stage. The next QI session, which is in July, we're going to talk a little bit about measurement and interpreting data. And then the third session will be sustaining and evaluation. So remember, you're in the first stages and it's okay to take your time. So check in with your QI coaches, because a little bit of work to do around establishing an ABC and a driver diagram, which I think will really help to move you in that sort of first stage of the journey. If any of you haven't been in contact with your QI coach, or you don't know what I'm talking about, please just put your email address in the chat and we will contact you. But hopefully you've all been contacted by your QI coaches. Following this session, we'll ask them to catch up with you and make sure you've got the resources and you've got a bit of a start for your project. The next event in our collaborative is actually the clinical event. So this is really going through the sort of quality standards within the Royal College of Physicians Modern Ward Round guidance. So clinical event session 1 is about the ward round environment. It's on the 24th of June between 1 and 2. Again, it will be recorded, very much like this. It's been recorded, and they will all be stored on our Futures NHS platform for you. On that platform will be other resources we find. So there is already a session on there about improvement science as well. So you can access other things as well on there. So not just these sessions. I've just put some direct links for you on this presentation so that you can access the IHI improvement resources and also the Royal College of Physicians improvement resources. Not the tools and models we've spoken about today. You can access them direct. And again, they will be on the NHS Futures platform as well. So hopefully you can access through those links. With the IHI resources, you do need to register and have a login. So you just need to do that a little bit first, but it only takes a couple of minutes. It's free, and then you can use those resources. The RCP one is free to access. And again, tweet any ideas and thoughts. The hashtag is Modern Ward Round MWR21. And there's our Twitter names on there as well for you.